In this module, we will discuss common complications from central venous catheter insertion and prevention measures. A primary driver of central venous catheter complication reduction is the use of ultrasound during insertion. Please remember that ultrasound guidance is recommended when inserting an internal jugular line and to a lesser degree when inserting a femoral line. There are mixed data with subclavian line insertion. Ultrasound-guided subclavian lines are not recommended unless you have particular expertise. Potential complications for central venous catheter insertion include air embolism, thoracic duct injury, malposition of the line, arrhythmias, thrombosis, infection, pneumothorax, hemothorax, wire embolism, and arterial cannulation. We are going to talk in more detail about several of these complications. Given all the data on complication risk, many authors feel that the subclavian vein is the best site for central venous catheter insertion. This table shows the complication rates associated with internal jugular vein, subclavian vein, and femoral vein central venous catheterizations. As you can see, subclavian vein thrombosis ranges from 0 to 13 per 1,000 catheter days depending on the study source. Therefore, using thrombosis rates to determine the best site for insertion is somewhat controversial. The arterial puncture data is intuitive based on an understanding of the local anatomy. Please note, when using proper technique with the subclavian vein insertion, there is the lowest rate of arterial puncture. These data are slightly old and do not take into account all the experience using ultrasound. As for pneumothorax rates, subclavian vein insertions range from 1.5 to 3.1%. This compares to the same or lower risk incurred during thoracentesis procedures. As for infections per 1,000 catheter days, the subclavian vein is the best site as well, then the internal jugular vein, and then the femoral being in last. The subclavian vein has the highest catheter malposition risk when the catheter crosses to the contralateral subclavian vein or ascends into the internal jugular vein. Mechanical complications including catheter misplacement, arterial puncture, pneumothorax, and hemothorax rise exponentially with more than 2 needle passes through the skin. Therefore, consider stopping after 2 attempts unless you can clearly determine why you were unable to successfully cannulate the vessel. As expected, the rate of mechanical complications at the subclavian site is lower with experience. However, this effect was not seen until the clinician had performed over 50 procedures. Take caution that years in practice is not a correlate for experience. Now let's talk about specific complications. Air embolism is one of the most feared complications related to central venous catheter insertion. It can lead to severe neurologic injury, cardiovascular collapse, and even death. Only 50 to 300 cc's of air inserted into a patient can cause these complications. Larger bore catheters have a higher risk of causing air embolism. You're not going to know how much air goes into the patient when this complication occurs because it happens very fast. An air embolism travels into the heart and can cause cardiac arrhythmias, pulmonary hypertension, and even cardiac failure from right ventricular outflow obstruction. If the patient has a patent foramen ovale, as many patients do, the air can cross to the left side of the heart and cause a stroke. Mortality is up to 30% with air embolism. Symptoms may be confusing because they can mimic a pneumothorax. However, without suspecting an air embolism, you will never diagnose it. Fortunately, an air embolism is a much less common complication than a pneumothorax. Patients may become tachycardic, tachypnic, develop cyanosis, have mental status changes, or hypotension. A classic mill wheel murmur may be heard across the precordium. Once you suspect an air embolism, the procedure should be terminated immediately. Some authors recommend an attempt at aspirating air back from the line or even advancing the catheter 2 centimeters beyond the right atrium and aspirating. Attempts to break up air bubbles should be considered. Gentle tapping on the patient's chest and a massage-like motion may be helpful at breaking up the air bubbles. Position the patient in the left lateral decubitus position as they are already in the Trendelenburg position. Proper position will allow the air to rise to the right side of the patient and prevents it from going across a patent foramen ovale. Cardiopulmonary resuscitation is usually effective in these patients because it helps to break up air bubbles. In emergency situations where nothing else is working, a thoracotomy can be performed. Hyperbaric oxygen treatment is controversial. The bottom line is when dealing with an air embolism, we need to focus more on prevention. Placing the patient in the Trendelenburg position increases the pressure in the venous system and makes air less likely to enter the vein. Keep the catheter system closed to air at all times. Flush all the lines and lock them, making sure they are occluded during insertion. Remember that during removal of lines, the patient should be placed in the Trendelenburg position and the patient should valsalva, hold their breath, or hum to ensure the intrathoracic pressure is high. The occurrence of air embolism is described in the literature up to 30 minutes after a line is removed. So remember, the initial dressing after removal should be occlusive. Arrhythmias usually occur from irritations of the right atrium or right ventricle either from the line or the guide wire. If this occurs, pull back on the line or guide wire and the arrhythmia should go away. Guide wire embolism is a complication that is rarely reported. This complication is reported to the Joint Commission as a retained foreign body if the guide wire retention is unknown at the time of the procedure. However, personal experience suggests that this complication occurs up to 4 to 5 times a year in large academic institutions. There are 2 known methods to prevent this complication. First, only insert 15 centimeters of the guide wire into the patient. The wire is approximately 50 to 60 centimeters in total length in most central line kits. Use the markings on the guide wire to estimate distance inserted. By not inserting too much guide wire, it is less likely that the wire will embolize. Another method to prevent guide wire embolization is to simply never let go of the wire during insertion. Another potential complication of central venous catheters is thrombosis. Thrombosis risk is highest in femoral lines. Get these lines out within 24 to 48 hours and avoid them in ambulatory patients altogether. Additionally, left-sided upper extremity lines appear to have higher rates of thrombosis than right-sided lines. Other factors associated with thrombosis include malposition of the line or not placing the tip at the atrial-caval junction, a high number of catheter lumens, multiple attempts to place the catheter which causes trauma and inflammation, and certain line materials and needleless connectors that cause negative displacement. There are 3 types of needleless connectors available: negative displacement, positive displacement, and neutral displacement. Negative displacement connectors have mechanical functionality such that when a syringe is screwed onto the connector, fluid or blood within the lumen of the catheter will be pushed out into the vein. When the syringe is removed, fluid or blood is sucked back into the catheter from the vein. Therefore, the catheter must be clamped before syringe removal to prevent this reflux of blood into the lumen of the catheter. If blood is in the lumen of the catheter, this can form a clot. Positive displacement connectors do the opposite. When a syringe is connected, fluid or blood is refluxed back into the catheter. When the syringe is removed, fluid or blood is pushed into the vein. Therefore, clamps should be closed after the syringe is removed from the connector. Positive displacement connectors usually require larger volumes of flush to clear the flow lumen of blood. These connectors are currently being evaluated by the FDA for concerns about increased risk of central line-associated bloodstream infection. Neutral displacement caps theoretically provide no displacement of fluid or blood when a syringe is attached or removed. Therefore, the clamping sequence does not make a difference. There are some data suggesting that neutral displacement connectors may reduce the incidence of central line thrombosis. There are many types of needleless connectors on the market. It is important to become familiar with specific manufacturers' guidelines on how to properly access and flush needleless connectors. We used to think that upper extremity deep vein thromboses should not be treated. However, recent recommendations by professional societies endorse treatment of upper extremity deep vein thromboses that are catheter associated. The American College of Chest Physician guidelines that were published in Chest in 2012 recommend that upper extremity catheter-associated deep vein thrombosis be treated up to 3 months with full anticoagulation. If the central venous catheter should be removed, it is suggested that removal occurs after at least 5 to 7 days of treatment in order to reduce the risk of thrombotic embolization during removal. Now let's talk about pneumothorax. Keep in mind that there are 3 types of pneumothoraces: primary, secondary, and iatrogenic. A classic example of a primary pneumothorax is the young man who smokes, who is tall and lanky, and comes to the doctor's office complaining of shortness of breath and chest pain. The classic example of a secondary pneumothorax may be the patient with cystic fibrosis or COPD that blows a bleb. Invariably, most of these patients will require air aspiration from their lung either by a chest tube or another mechanism in order for these to resolve. This is in contrast to iatrogenic pneumothoraces, which have a higher threshold before intervention is required. If the patient has mild symptoms or less than 40% of the hemithorax is affected, it is reasonable to use expectant management with serial chest x-rays and supplemental oxygen. If the pneumothorax is expanding on subsequent chest x-rays, or if the patient has significant symptoms, or if the pneumothorax is greater than 40% of the hemithorax, it is recommended that the pneumothorax be aspirated or a chest tube placed. However, please take note, the 40% cutoff is very rarely seen in clinical practice because when looking at a chest x-ray, it is quite difficult to determine the difference between 30%, 40%, and 50% of the hemithorax. In my experience, usually the patient's symptoms guide whether intervention is necessary. Ventilated patients usually require a chest tube no matter what size a pneumothorax because the positive end expiratory pressure can cause a tension pneumothorax. Hemothorax is caused by nicking an intrathoracic vessel. The event of nicking a vessel while placing a subclavian line may require chest tube placement and a surgical consult. Consultation should be emergent because these vessels at the subclavian site are not compressible and the patient could have serious bleeding complications. Now let's discuss entering versus cannulating the artery and what to do if you suspect these complications. Please keep in mind that entering the artery with a finder needle is thought of differently than cannulating the artery with the dilator or catheter. Entering the artery with the finder needle may have consequences at the subclavian site. Remember that this vessel cannot be compressed easily and it is prudent to consult with a surgeon if the artery is punctured. If the finder needle enters the carotid or femoral artery, hold direct firm pressure until hemostasis is achieved. Many experts recommend that cannulation of the artery is a surgical emergency if the line is greater than 7 French. Most triple lumen catheter kits are right at about 7 French. In the event that a catheter is placed in the carotid or subclavian artery, please consult with a surgeon immediately because several experts recommend that these lines be removed under direct visualization. Do not attempt to remove these lines until directed by a surgeon. Femoral artery lines can be removed with direct pressure, but it may be prudent to consult with the surgeon as well. Consider formal imaging studies of any cannulated arteries after the line is removed to rule out pseudoaneurysm or other complications. Because the consequences of arterial puncture are significant, verification that the target vein has been cannulated is strongly recommended. The use of blood color, waveform analysis, pulsatility, or blood gas analysis are not recommended for verification due to the high likelihood of confounding states from low blood pressure or shock states. The 2 verification strategies with the greatest degree of overall support are pressure transduction of the target vessel, otherwise known as manometry, and the use of ultrasound imaging to confirm vein cannulation. If fluoroscopy, catheter tip electrocardiography, or transesophageal echocardiography are available, case reports and observational trials support their use for verification purposes. The choice of verification technique should depend on operator experience and technical issues. Consider using manometry only with the modified Seldinger technique because use of manometry with the Seldinger technique is technically more difficult than with the modified Seldinger technique. Let's talk more in detail about infections. Central line-associated bloodstream infections, otherwise known as CLABSIs, cause significant morbidity and mortality, are not reimbursed by Medicare, and are preventable. As I mentioned, the highest risk of infection is at the femoral site, so these lines should be avoided. Previously, lines were removed at 5 to 7 days because literature showed that infection rates increased exponentially at about a week after line insertion. However, we now know that routine line changes does not affect this rate. Lines should not be changed over a wire to reduce infectious complication. If a line is clearly still needed and the line site looks good and intact, there are lacking data to suggest removal or exchange. The next thing I want to discuss is central venous catheter bundles. A bundle in healthcare is a group of items that individually have been shown to affect patient outcomes in a positive way, and when brought together in a care package, they are called a bundle. We have a ventilator-associated bundle, we have a urinary tract infection bundle, and the list goes on. We also have a central venous catheter bundle, which is specifically used to prevent central line-associated bloodstream infections. The bundle includes 6 items: appropriate hand hygiene prior to placing a line, maximum sterile barrier, that means you wear a hat, a mask, sterile gown and gloves, and you use a full sterile body sheet and appropriate sterile dressing to the ultrasound machine, chlorhexidine skin antisepsis, which has been shown to be superior to iodine in studies, avoidance of the femoral vein with its high rate of infections, daily review of line necessity, and certainly removal of all unnecessary lines. Central line bundles have been validated by Pronovost and others in the New England Journal of Medicine, where they did a study across intensive care units in Michigan and showed a significant reduction in central line-associated bloodstream infections. Other methods recommended by the Center for Disease Control to reduce infections include reducing the number of lumen in the central venous catheter to only those that are needed. Although there may be conflicting evidence, extra lumen are accessed more frequently and, as mentioned previously, tend to thrombose more, which is also a nidus for infection. Using a sutureless securement device for central venous catheters is strongly recommended, but may only apply to peripherally inserted central catheters, otherwise known as PICC lines. However, for shorter-term lines, this is not a proven technology. Refrain from using topical antibiotic ointment or creams except for consideration on tunneled hemodialysis catheters. Topical antibiotic ointments and creams promote fungal growth. Sterile gauze or transparent semi-permeable dressings can be used to cover the site. Gauze is recommended for sites that are bleeding. Replace gauze dressing every 2 days and replace transparent dressings every 7 days. Some hospitals use chlorhexidine impregnated sponge dressings. This is only recommended if the rate of infections is not decreasing despite basic prevention education and training with appropriate chlorhexidine skin antisepsis. The use of 2% chlorhexidine daily washes has been shown to reduce CLABSI rates. This was confirmed in a recent multi-center study published in the New England Journal of Medicine in 2013. The Center for Disease Control recommends the use of chlorhexidine silver sulfadiazine or minocycline rifampin impregnated central venous catheters only in those patients whose catheter is expected to remain in over 5 days and if after successful implementation of CLABSI reduction strategy, rates are not decreasing. However, concerns about bacterial resistance to antibiotic impregnated catheters have prevented their widespread use, although this has not yet been proven in the literature. Please note any patient allergies prior to insertion because there can be reactions to the antibiotics in the lines. As previously mentioned, there has been some recent concern about positive displacement needleless connectors. With these connectors, fluid is positively displaced from a catheter after removal of a syringe from the connector. Many experts recommend neutral displacement connectors where this does not occur. However, the bottom line is that improper line maintenance techniques are likely what is driving infections, and it is unlikely related to the type of needleless connector. Consider antibiotic locks in patients with long-term catheters who have a history of multiple central line-associated bloodstream infections despite adherence to other techniques. Finally, let's look at another real patient example that illustrates the need for thoughtful interpretation of the possibility of an arterial cannulation. The patient was a 45-year-old female with end-stage renal disease on hemodialysis who was admitted to the medical intensive care unit with sepsis from pneumonia. A right internal jugular triple lumen central venous catheter was inserted. Upon drawing blood from the line, the nurse noted that it was bright red and looked arterial. Since the line was already in place, a blood gas was sent from the line and from the left radial artery. The partial pressure of oxygen from the central line was 72, while it was 94 from the radial artery. These results suggested an arterial partial pressure of oxygen at both locations with a drop-off in the central line drawn specimen. It was felt that the radial artery blood gas was more likely representative of the true arterial partial pressure of oxygen. The explanation for the step-off in the blood gas from the line was that the patient had an arterial venous fistula in her right arm. Therefore, the vein was still receiving partially arterialized and oxygenated blood. If there are any questions, please direct them to the individual clinician that is the instructor at your site. Thank you for listening.